Again, I'm Dr. Jonathan Kaplan. I'm a board certified plastic surgeon in San Francisco. Hopefully saw all of you, most of you this morning for the first session when we were talking about how to structure and build your weight and wellness program. From Dr. Well, that company, we have this offshoot. What we found was there was an opportunity for a novel medication, a novel combination. And what I wanted and that was the launch of Mino Meds. What I want to talk about though is the fact that everybody can get GLP-1s now. It's very easy. So you've got to provide a very easy, frictionless process for patients to sign up, which is what Dr. Well was talking about this morning. But then you also have to have a service, an offering that is unique, that's not commoditized yet, and not only a service as far as a medication, but maybe also an indication. And that's what I want to start with here is a possible new indication for GLP-1s. And you probably have heard a little bit about this, but I want to go into more detail. There is an unmet need in alcohol use disorder where GLP-1s may have an opportunity. Alcohol use disorder, it affects over 28 million US adults. There are currently FDA-approved agents, but not GLP-1s, and they have moderate effect on the patients. There's a low long-term adherence to these medications. A lot of them are pills. High relapse rates, significant medical, social, economic burden associated with alcohol use disorder, of course. And so there is a need for a mechanistically novel approach to this. And as this article on the right shows, that there is an association, a very high, significant association between obesity and binge drinkers. And so enter GLP-1 squared, a combination of semaglutide and tirzepatide. And we did start off thinking about this for alcohol use disorder, which could be a novel indication for using a novel combination therapy. But we didn't start out with alcohol use disorder. What we noticed in our clinic, as I mentioned, I'm a plastic surgeon in San Francisco. We have a large weight and wellness program in our practice. And our nurse practitioner, who's also the chief nursing officer of Dr. Well, and also is there to help all of our providers with Dr. Well, but she noticed within her patients, or our patients, that the ones that weren't losing as much weight on semaglutide requested, or we offered to switch them over to tirzepatide. Once we switched them over to tirzepatide, they did have some greater appetite suppression, but they had more food noise. And so even though they had appetite suppression, they were still thinking about food all the time, so that maybe they would sit down to eat or sit down to snack more often than they normally would. And yeah, maybe they wouldn't eat as much, but they're still sitting down to snack and eat more than they normally would because they had more food noise, thinking about food, thinking about what they're going to eat next, where they're going to eat it. And so we thought, okay, well, if semaglutide has better food noise suppression and tirzepatide has greater appetite suppression, what about combining them? And that's what we did. We reached out to our one of our partner 503A pharmacies through Dr. Well and talked to them about that, and they thought it was a genius idea. Because the thing is that even though obviously there's no FDA-approved indication for combining semaglutide and tirzepatide, the fact that they are both individually FDA-approved medications makes it okay to combine them in an off-label way. It's totally legal. And then we are seeing that now we're sourcing it from more than one 503A pharmacy. And we're seeing a potential benefit in the motivation reward system, which people often refer to as the limbic system. So again, GLP-1 squared, it's the combo of semaglutide, tirzepatide, but we are actually doing this at lower doses. There's 5 steps to the dosage protocol that we have. And in those 5 steps, each step, it's a lower dose than each of the medications individually. So the rationale why we think GLP-1 squared may be stronger than single agent therapy, specifically for alcohol use disorder. And also, even though you may not be an addiction specialist, although you may not be using it for alcohol use disorder, we are using it off-label for weight loss and any type of potential craving that people have, whether it's smoking, drinking, eating. Me personally, I'm taking GLP-1 squared at the lowest dose of this dosage protocol that we've come up with that we're working with our compounding pharmacies on. Anyway, but the combination GLP-1, semaglutide combined with a GIP GLP-1 agonist, which is tirzepatide, they do both overlap on the GLP-1 receptor, but they don't overlap and bind to the GLP-1 receptor in the same identical way. And that does lead to different downstream effects. And because you have this parallel stimulation of these two receptors, it ends up having a difference in the neurocircuitry where it's driving, that's reducing craving and affecting reward, impulsivity, and relapse. And the other thing that I'm going to talk about a little more detail that we're finding from a theoretical standpoint is that the combination of these two medications on the GLP receptor may actually keep the GLP-1 receptor on the cell surface for longer, meaning that people become less desensitized, stay sensitized to the effects of these medications on the GLP-1 receptor. But I'll get more in detail about that in a second. And also, because of the fact that we're using lower doses for the combined therapy, it obviously reduces the potential for that side effect burden that is associated with getting to the higher doses. So, quick overview, you've got the semaglutide model on the left, you've got the tirzepatide molecule on the right. The semaglutide is slightly smaller than tirzepatide. And then when you look at the receptors, the semaglutide is a full agonist of the GLP-1 receptor. It binds much more strongly to than tirzepatide binds to the GLP-1 receptor, and that's why they have different downstream effects because they bind in different ways. Whereas with the GIP receptor, semaglutide has no activity, but tirzepatide does, of course, have activity in GIP and actually is high equivalent affinity to the native gastric inhibitory peptide. So this is the profile of semaglutide, tirzepatide, mostly probably a review for a lot of you. But yes, semaglutide binds just the GLP-1 receptor more strongly than tirzepatide. Tirzepatide binds to both. So this is really where it gets into that idea that these medications, the combination, may keep the receptor on the cell surface longer, lead to any sensitivity or maintain sensitivity and reduced desensitization. So when semaglutide binds to the GLP-1 receptor, we're only talking about the GLP-1 receptor at this point between semaglutide and tirzepatide. When semaglutide binds to the GLP-1 receptor, it has something called a beta-arrestin recruitment. It recruits a protein called beta-arrestin that actually leads to the internalization of the GLP-1 receptor over time, meaning that when semaglutide is trying to bind to the GLP-1 receptor, because it increases the beta-arrestin protein recruitment over time, it leads to more internalization of the GLP-1 receptor, meaning that semaglutide has nothing to bind to over time, which is why some people become desensitized to semaglutide. It stops working, basically, because the semaglutide pathway through GLP-1 bringing this beta-arrestin protein, internalizing the cell, it's no longer available to be bound to. Whereas with tirzepatide, it doesn't go through that beta-arrestin pathway. It goes through cyclic AMP pathway, which then, because there's less beta-arrestin, that protein is not internalizing the cell. It keeps the GLP-1 receptor externalized on the surface of the cell so that it is still available to be bound to by semaglutide and tirzepatide. So that's what a weaker GLP-1 receptor internalization with the tirzepatide, meaning it just the cell's receptor stays outside, externalized longer than being shifted inwards as happens with semaglutide pathway. So with this mechanistic rationale of semaglutide, it saturates the majority of the receptors of GLP-1 wherever they are: hypothalamus, hindbrain, the ventral tegmental area. All of these areas can be involved in, appetite and these different cues for people for alcohol use disorder. And it reduces that appetite and the reward salience, meaning salience in this context means that you have this outsized disproportionate interest in seeking out that reward. And so semaglutide, by binding to all these receptors, reduces the appetite, the salience, and those alcohol cue-driven dopamine spikes. It also just helps reducing the cravings in general, and also therefore leads to clinically reduced alcohol intake, binge episodes, hedonic drive. Now look at tirzepatide. Maybe it doesn't bind to the GLP-1 receptor as well, but as I mentioned, with that beta-arrestin protein, it decreases sensitization, maintains sensitization, keeps that GLP-1 receptor outside of the cell. And then it directly dampens the dopaminergic firing in the ventral tegmental area, which is very relevant for alcohol use disorder as far as relapses. And it has effects on other parts of the brain, reduces compulsive behavior, and reduces stress-triggered reinstatement, meaning that reducing recidivism. So why this lower dose dual therapy, lower dose meaning that semaglutide, tirzepatide at lower doses, why may it outperform high dose monotherapy of each individual medication? Well, so of course the monotherapy, if you're not having the effects you want with the monotherapy, you have to keep increasing that dose, which of course leads to GI burden. It leads to tolerability issues, the side effects. As far as the dual therapy at lower doses, you've got coverage of both semaglutide, tirzepatide on the GLP-1 and GIP, but also more coverage of that GLP-1. So it expands receptor coverage and inhibits receptor internalization, the GLP-1 receptor, as I've mentioned, broadens the neural impact, and avoids those side effect thresholds associated with the higher doses that could limit clinical use. And so eventually, because we're reducing the dose, we're minimizing toxicity. How we're using GLP-1 squared in my practice, but also across all of the Dr. Well network over the last year, our providers, 57 providers, unique providers have submitted over 1,200 orders for GLP-1 squared, getting multiple vials of some. So we've actually the patients in general have received over 1,300 vials of this medication over the course of their treatment. And so while we are utilizing this for all types of indications, not official indications, of course, it's not FDA approved, but for all of these off-label indications, alcohol use disorder, but also helping suppress appetite, helping people who have food noise when they switched to tirzepatide, but didn't have the same appetite suppression they wanted on semaglutide, using GLP-1 squared for appetite suppression as well for any off-label indication. Now, even though we are using it for all these things for these off-label indications, we do want to put a ring on it and make it somewhat official. So we are currently working with a CRO, which is a contract research organization, to submit GLP-1 squared to the FDA as an investigational new drug, an IND. So this is a very legal, expensive pathway to not necessarily, it doesn't make it a commercially available drug, but it does start that path to then investigate becoming a commercially available drug. But at least in the meantime, it makes it more official that you can now, by going through an investigational new drug pathway, now you can actually study this. It's not just anecdotal experiences, which anecdotally I can tell you that nobody is having major adverse reactions to this. If even one person had pancreatitis, we wouldn't be offering it. But it's clearly working. It's working for me. I'm taking it, as I mentioned, the great thing I find about it is that instead of, like, if I was on low dose tirzepatide, I'd start getting really hungry at day 5. With GLP-1 squared, I've got this just low, even killed, maintained reduction of appetite and food noise throughout the entire week until my next shot. I don't get this rebound, like craving, ravenous experience at day 5. So that's what I've been really pleased with it. But again, we are going through this process with the CRO for an IND specifically for alcohol use disorder. We are not trying to get an IND or an approval for weight loss. It's been done. We're looking at it for alcohol use disorder. But again, I want to stress that just because we're looking at it to make it official for alcohol use disorder, it is available now off-label for weight loss, AUD, or any bona fide medical reason you're interested in offering this. So again, it's really only available through us. Can you get semaglutide and tirzepatide on your own and you have a patient give themselves 2 shots? Sure, go for it. And let us know how the patient experiences taking 2 shots a week rather than 1. But also, we have designed this protocol, this 5-step protocol of reduced dosing combined, and then the concentrations, of course, work in the compounding pharmacies that we're working with. But as far as just kind of bring this all together, the co-administration of the 2 medications together, of course, it reduces the fact that the patient's not having to do 2 injections each week. But also, we have this, because we have this high occupancy of the GLP-1 receptor, specifically by semaglutide in all of the areas, hypothalamus, ventral tegmental areas I mentioned, that is one big benefit of the semaglutide. It binds more strongly the GLP-1 and the receptor, and that can lead to some of these benefits we're talking about. But then the tirzepatide coming into it, it also binds, of course, to the GLP-1. And we think that it actually keeps the GLP-1 receptor externalized, available for binding longer. So that means people can be on these medications for chronic use at lower doses and be beneficial. So that's the benefit of semaglutide, is it binds more strongly for the effects we're looking for. Tirzepatide binds also maybe weekly, but it still binds and keeps the receptor out so the patient stays sensitized to it. And then the third benefit, of course, is the GIP has that unique activation from the tirzepatide. So we're creating a three-pronged approach to helping patients with whatever craving that they're trying to address that neither drug alone can replicate. So it's very, very exciting. And again, it's not a novel combination at lower non-commercial doses. So if you are worried about whatever FDA enforcement there may be, this is a combination. This is not commercially available, and while it does have a higher cost of goods, you obviously can charge more, and it is a unique offering to patients. So it's very, very exciting. And when we get into this IND pathway and we need clinical centers, we will need primary investigators to help us with evaluating this medication. But again, you can still offer it now, but we just can't study it now. That's not ethical or legal. So if you have more questions about GLP-1 squared or Meds, you can visit us at this QR code. You can email me at drkaplan@drwell.com. But this is our website where we go through everything about GLP-1 squared, where we explain the differences, a lot of what I just explained to you, and how it's a complementary pathway, how you can utilize it, and how you can get access to it now. So thank you very much. Please take a picture of that QR code, and we will be happy to reach out to you. We have some questions, I think.
Yeah, I'll sneak back in for questions. There's one on here, and I think this is probably at the top of everyone's mind, but retatrutide, I've heard it pronounced both ways. But hopefully it seems like it's coming towards the end of the year, but where does it fit into all of this?
So certainly retatrutide, that's certainly an option. We don't, it's not legally available yet. So for anybody that is getting it, it is research grade. So that is certainly an opportunity for another drug. That's not going to be the last drug. There's eventually going to be more drugs specifically for alcohol use disorder. There's going to be once a month injections. So specifically about retatrutide, yeah, it's very exciting.
And then specifically on the compound of the combination, does that affect dosage, and then recommendations on how you're titrating up on the dosage?
Yeah, we do. For anybody that does sign up and gets access to GLP-1 squared, we lay it out for you. We have these treatment protocols, just the same way we have all these AI support for treatment and treatment protocols. You don't have to think of any of this on your own. We've got a 5-step progression for GLP-1 squared, a couple different concentrations. But yes, we provide you with the very clear breakdown of what the dosage is for each the semaglutide and tirzepatide in the combination vial, and what amount, how many units you would provide for that lowest dose, then the next step, the next step, the next step, the next step. So yeah, we lay that all out for you.
And then for the GLP-1 squared, can you have it compounded with B vitamins?
So we are choosing not to combine it with B vitamins. We would not be getting it compounded for B vitamins at this point. It's certainly possible with our compounding pharmacy partners. Certainly, we could add B vitamins in. But as far as what we're doing with the IND application with the Contract Research Organization and the FDA, we are not adding additives just to not muddy the waters, but also the FDA doesn't need us to add additives to it. They're more than happy recognizing the fact that this is a novel combination of semaglutide, tirzepatide. So whatever benefits you feel like there are B12, like as far as from a regulatory standpoint, that's not necessary here.
And then are you finding that the combo version has higher, lower, or similar side effects versus using one versus the other?
Yeah, so there's no question, and it's a little bit counterintuitive, that if you have two medications, maybe you have double the side effects. But anecdotally, that is absolutely not the case. Especially personally, I can tell you, definitely whatever, like I'm not having more nausea or more constipation or whatever side effects you may have. It is really a very interesting experience in me personally, and I've been taking it for a year now, that it really is a very low level experience that you kind of forget that you're taking the medications, because it's just this even keeled effect throughout the entire week. There isn't this spike of like, oh my God, all of a sudden you're so hungry, or that you're doubled over in pain or nauseated or anything like that. And I'm not trying to, give you an unrealistic expectation, just say it's all great, but I have not any of those concerns to be true as far as doubling of medication. And of course, again, it's at lower doses, but I've not seen that there's an increased risk of side effects. Because if there was, we would have been hearing about that from our providers.
And this one you might not be able to answer yet, but benefits of the GLP-1 squared versus Retta.
Well, I can't answer that because I've not taken Retta since it's not FDA approved.
And then what is the clinical indication when ordering
The GLP-1 squared?
Yeah, yeah.
Yeah, it's the same thing. And not so in our platform, when you go to order the GLP-1 squared, like so that you send the patient a link through the platform through Dr. Well, they sign up, charge through a high risk payment processor on a nice mobile friendly interface. Once they're charged, that auto generates a prescription in the back end of the platform. And then what happens is you go in, and when you go to submit the order, you have a drop down of choices. And one of the choices would be that it's not commercially available, which is not. The combination is not commercially available. And with the pens and things, as far as Ozempic or Wegovy, the pens, you're not going to be able to get these different dosages. So that's why it is truly, from a regulatory standpoint, not commercially available. And so, yes, we're going to submit the order. We already have that reasoning for you that you would choose from that drop down that is specifically that it's not commercially available.
And then do you find incontinence with this medication?
Incontinence? Absolutely not. I guess that would be awkward to out myself for incontinence. And I'm not making a joke about incontinence, but no, I've not noticed any issues with incontinence.
All right. It looks like that was the last question.
Great. That was a good one to end on.
That was a great one to end on. Well, thank you so much. I'm so glad
pleasure
you're
being
able to
here.
be here with us in person today.
No, thanks for hosting it in San Francisco.
Yes, it's nice to get everyone together. All right.